Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. Gout is every rheumatologist's favorite topic, but wouldn't it be wonderful if there was a way to detect which patients will respond to urate-lowering therapy and go into remission? The manuscript we'll discuss today is Baseline Dual Energy Computed Tomography. Urate volume predicts fulfillment of gout remission after 2 years of urate-lowering therapy. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes from today. I'm so happy to be joined today by two of the authors of this study who are joining us from New Zealand. Dansoa Tabi-Amponsah is the study's first author and a PhD candidate at the University of Auckland, New Zealand. Dansoa graduated first class from the University of Otago with a Bachelor of Biomedical Sciences, and she's been a PhD student for about 2 years. Still, in that time, she's published 5 first author manuscripts on gout and predictors of gout remission. Dr. Nicola Dalbeth is the senior author of this study, professor and head of the Department of Medicine at the University of Auckland. She's an accomplished academic rheumatologist who leads a clinical and laboratory research program in gout. And she's also been a member of the core leadership team of the ACR Gout Management Guidelines and a steering committee member of the Outcome Measures in Rheumatology, or OMERAT, Gout Group, as well as the ACR EULAR Gout Classification Project. Welcome to the show, Dansoa and Nicola.
Thank you.
Hi, Vicky. Nice to see you.
So, Nicola, I'm going to start with you. You were part of the team that in 2016 established the consensus preliminary gout remission criteria using the OMERAT core outcome domains for long-term gout studies. Can you tell us about those domains? What are their limitations?
Yeah, sure. So in 2015, 2016, a group of rheumatologists and gout researchers came together. This was work led by one of my fellows, Hugh de la Tour. And essentially, we came to a consensus agreement about a preliminary gout remission criteria. We felt that actually gout remission was an important construct and it should be a treatment aim. So essentially, we, through a sort of process of consensus with 1,000 Minds, we identified 5 domains. And in order to be considered in gout remission, all of these domains had to be achieved. So this was essentially low levels of pain due to gout, low patient global assessment scores, absence of tophi, absence of gout flares, and serum urate below 6 milligrams per deciliter or 0.36 millimoles per litre. It's very tight. It's really hard to get into remission with all of these variables. There are also time-related variables. So essentially, you have to have persistently low pain scores, patient globals, serum urate levels. But we really feel that this is the target that we should be aiming for and can achieve in people with gout. So that was really the preliminary criteria. And we've done really quite a lot of work since then to try and understand whether this is the right definition, also actually how we can predict who's going to be in remission. And this is work that Dansoa's obviously done in this paper. And also thinking a little bit about whether we can simplify the definition. And that's also been work that Dansoa's been doing throughout her PhD. But really in the study that we're going to talk about today, we were really interested in understanding for people who are starting urate-lowering therapy or having intensification of their urate-lowering therapy, can we somehow predict who's going to be in remission based on these criteria?
So why was this study needed? What was the real question that your investigative team was trying to answer?
The original trial or the particular paper that we're going to be talking about today?
So tell us about this particular paper, and then we're going to do the actual original trial next.
Okay. So essentially, the paper that we're going to discuss today was really asking the question, can we identify which patients or which variables are likely to predict remission or predict people who might require more intensive treatment or might take longer to actually get into remission? And so we use data from an existing clinical trial to try and answer that question.
Okay, well, you've lined us up nicely. So tell us about the study from which the data was drawn. And in particular, can you tell us a little bit about the patient population and the characteristics of the patients?
Yeah, sure. So the original trial was published in Arthritis and Rheumatology in 2022. And essentially, it was a randomized controlled trial of patients with erosive gout. And the trial essentially was a trial looking at 2 different serum urate targets. So this work really arose from quite a lot of work that we'd done in our group previously, trying to understand the mechanisms and treatment of erosive gout. And this is an issue that we deal with in our clinical practice a lot in Aotearoa in New Zealand, where we frequently see people with very severe tophaceous gout who have a lot of joint damage as a result of their tophi. So for many years, we've been very interested in trying to understand the mechanisms of tophaceous gout, of bone erosion, and also treatment approaches. And in previous work, we'd analysed data from pegloticase studies, where obviously the serum urate is very low, and demonstrated actually some bone remodelling and infilling of erosions. We'd also previously published an allopurinol dose escalation study and demonstrated with a treat-to-target approach, we can actually prevent progression of bone erosion in people with gout. So that was really the sort of background to doing this trial. In this trial, we were testing two different serum urate targets. One was the sort of standard target that we would use with people with very severe gout, which is below 0.30 millimoles per litre or 5 milligrams per deciliter, or an even lower target of 0.20 millimoles per litre. And so that's essentially 3.3 milligrams per deciliter. So that's kind of trying to head down into that pegloticase, very, very low urate lowering target with oral therapy, which actually, as it turns out, is really quite difficult, as we showed in the study. So essentially, the key outcomes from that study was that in both groups, there was clinical improvements, so fewer flares, reduced tophus size, and improved patient outcomes and patient-reported outcomes. And really, for both groups, we saw a sort of flattening of the bone erosion scores. So we didn't see a whole lot of progression, but we didn't see any infilling or improvement in bone erosion. It was also, to be honest, really hard to get people to that very low target. Patients had a lot of changes in their medications. We used maximum doses of all the available oral urate-lowering therapy that we had available to us. So that was allopurinol, probenecid, benzbromarone, and febuxostat, often in combinations as well. So there was a lot of therapy, and overall similar clinical improvement in both groups. So I think this was actually, from a practice perspective, really quite useful. I think it has certainly changed my practice. And now, for those patients with severe tophaceous gout with bone erosion, I really do want to get the serum urate below 5 milligrams per deciliter or 0.30 millimoles per litre, but I don't necessarily sort of try and push them down a lot lower than that.
And I should mention that a couple of those agents are agents that are available in the US, so allopurinol and probenecid, yes, but benzbromarone is actually not available in the United States because of a hepatotoxicity issue, and I think is not available in some parts of Europe. And essentially, if you didn't control uric acid with those three agents in combination, then you would switch to febuxostat as monotherapy. Is that
that's
correct?
Right. Yeah, that's correct. And we were able to go up to 120 milligrams of febuxostat, which is our approved dose, highest dose in New Zealand, which is obviously higher than in the US, for example.
Yes. Okay. So, very complicated study. Let's talk a little bit about the baseline examinations. You measured obviously a lot of baseline demographics, self-reported pain and health scales. But then, of interest to this particular analysis, you also conducted a baseline and then annually dual energy CT or DECT scan of the feet and ankles. Can you tell us a little bit about using DECT as a tool for measuring uric acid or monosodium urate crystal deposition, and in particular about using it to assess for erosions?
Yeah, sure. So, this is a really amazing research tool when you're doing gout trials, because you can visualize and measure the volume of MSU crystals. And we also get conventional CT images as part of the dual energy series. And so this is also a very good measure of, or allows us to measure bone erosion very comprehensively as well, essentially with 3D images. So a really fantastic tool. We've used dual energy a lot in our research, particularly when we're looking at mechanisms of MSU crystal deposition and bone erosion. And we've used it a lot in our trials as well. So many years ago, we actually validated a CT erosion score for use in gout. It's still a very labor-intensive process when you're scoring bone erosion, but it's a very useful scoring system, and it's one that we use in our clinical trials of bone erosion and gout. So it really gives us a lot of information. So it allows us both to measure MSU crystal volumes. using the Singo software in this setting, and also allows us to measure bone erosion very accurately.
Okay, so you followed these patients every 3 months for 2 years. What follow-up measurements were taken during that time, and how did you then assess remission for the patients?
Yeah, sure. So essentially the dual energies were done once a year, but as well as that, as part of the study visits, we essentially measured all of the OMERACT core outcome domains. And so that includes those variables that were actually included in the remission definition that we talked about earlier. So essentially, this included pain scores, patient global assessments of disease activity, flare data. So we have basically flare data for every 3 months, and also the presence of subcutaneous tophi. And the serum urates were obviously measured because that was part of the study as well, because we were doing essentially a testing to treatment serum urate targets. So essentially we had all of the variables that we needed to analyze the remission criteria. And so essentially this was a really fantastic data set where we had a lot of baseline variables, including the dual energy, and then we were able to look at remission at the subsequent time points within the trial using the data that we'd actually collected.
Yeah, it's fantastic. So now I'm going to switch over to Dansoa and bring her into the conversation to answer some of the harder questions. So you, Dansoa, conducted much of the study's analysis. Would you share with our listeners how you did that analysis and what specific tools you used to identify potential baseline predictors of gout remission?
Yeah. So to start off with, the baseline variables we looked at to identify potential predictors of gout remission, those were selected based on clinical knowledge and Nicola's expertise. And so those are the variables present in tables 1 and 2 of our manuscript. These potential predictors of gout remission were initially assessed using univariable logistic regression. So that was just looking at the association between a single baseline variable and the achievement of remission. So those variables with associations that had p-value less than 0.15 in univariable analysis were used to build predictive models by systematically selecting predictors that significantly contributed to the models. And so we used traditional selection techniques and a newer, less so logistic regression. And so this was done to produce a final multivariable model of predictors that had a good fit, were simple and plausible. And so from this, we identified dual energy CT MSU crystal volume as a significant predictor of gout remission.
Okay, so it kind of shook out all of those other variables and kind of honed down on the dual energy CT. Can you fill us in on a few of the other data from this study? So what percentage of the total number of patients in the study actually achieved remission? And what else can you tell us about the analysis?
So I just focus on year 2. So at year 2, about 23% of participants fulfilled the preliminary criteria. So it doesn't seem like a lot because the criteria is quite tight. But also as part of my PhD, we are interested in simplified criteria for gout remission. And so that's the domains without it's a preliminary criteria without the patient-reported outcome domains. And so using that simplified criteria, more people, 44%, were identified as being in remission. And we also report that in the manuscript. But back to the baseline predictors, DECT MSU crystal volume was the only significant predictor in the multivariable models. And so a higher MSU crystal volume was significantly associated with lower odds of reaching gout remission. And it actually remained a significant predictor when controlling for baseline tophus. That was also a good insight showing us that despite the presence of tophus count in the model, DECT was still a very strong predictor. We also explored this further through ROC analysis, and we determined a cutoff value to estimate the probability of no remission. And so participants with an MSU crystal volume greater than 0.11 centimeters cubed at baseline were much more likely to not be in remission, and that had a positive predictive value of 9
It's kind of interesting because to some extent it's probably not a huge surprise that a larger crystal burden correlates to lower probability of remission. But I'm wondering, did the aggressive therapy arm do any better, or did it really not make a difference how aggressive you were with escalation of therapy?
In the original study, there was no difference in outcomes between the intervention groups. And that's what we found here also. The intensive therapy arm did not make any difference in fulfillment of remission.
Yeah. And how much of that, I guess, was due to that patient-reported pain outcome score that seemed to be the lingering, challenging to meet part of the criteria?
Yeah, so very few participants fulfill the pain due to gout and patient global assessment questionnaires. And I think you see that more when you see how many more people were able to fulfill those simplified criteria that the PROs.
And so, Nicola, back to you for a little bit. What does this mean for patients? How should patients with significant crystal burden be counseled as they start therapy? And can you tell me, how do you, as a physician, use these results in your own clinical practice? Do you order DECT for all patients? And if not, how do you decide when to order it?
So first, I guess answering your first part of the question, I think for me, one of the really interesting things is just thinking about the patient population here. So this was a group of patients with really pretty severe disease. Most of them had tophi at the time of their initial presentation or entry into the study. They all had a rose of gout. And even in this population, which is, I think, the more severe end of the spectrum, remission over 2 years with urate-lowering therapy, it was possible in a reasonable proportion of these patients. Not all of them, but I think it really says to me that remission should absolutely be the goal of therapy for people with gout. It's obviously much harder if you've got high MSU crystal burden. So I think the first thing to say is that we should really be trying to treat gout much earlier, so we're not actually getting this big crystal burden, which then means it takes a lot longer to actually get into remission. But also, I think it is useful to help manage physician expectations, patient expectations around actually this is going to be a long journey and it is going to take maybe more than 2 years to actually really get things under good control and to get that remission state. So I think it's useful when you're thinking about the expectations of how long it's going to take to really see that clinical benefit, but also just really we need to be treating people earlier so we're not getting this really large crystal burden. Because once we see that, it takes a long time to see clinical improvement. And I think also coming back to the original results of the trial as well, we weren't seeing improvements in bone erosion scores with oral therapy. So, once you've got bone erosion, it's really hard to turn that back. And we really want to be treating people before they're getting extensive tophi and bone erosion. And often we don't see that happening in our communities. And then about your second part of the question, how do I use DECT in my clinical practice? I certainly don't check a dual energy CT for every patient I see in clinic. I think DECT is it's a fantastic research tool. I think it provides a lot of information to patients. They can really visualize their disease. I think I've learned so much as a rheumatologist and as a researcher from looking at these scans, really understanding the disease in a way that I didn't understand it before. But I think in my own practice, I would maybe I could go for months actually. And I see a lot of people with complex gout and I could go for months without requesting a dual energy CT. Most of the time I'm diagnosing and assessing gout based on my clinical expertise. So my history and physical examination. I use a lot of bedside ultrasound, MSK ultrasound, which I think is really helpful for helping again people to see double contour sign, tophi, bone erosion. It's very easy within the clinic to do that. And the situations where I would use dual energy in my clinical practice is if I see a patient who's maybe presenting with a sort of subcutaneous nodule that I can't needle and I can't quite work it out on ultrasound. That's a situation where I'd be thinking, is this a tophus? Is this some other kind of nodule? And I think dual energy is incredibly helpful there. The other place where I've used it occasionally has been when I've got a patient where I'm very comfortable that I've made a diagnosis of gout, which I'm very comfortable with it. I've treated them for quite a prolonged period and they're still having flares or they're still really not responding with the standard urate lowering therapy in the way that I would expect. And sometimes in that situation, actually getting a dual energy, I think is very useful just to estimate how much crystal they have left. And if they've still got a lot of crystal on dual energy, I'll be much more comfortable to say, right, we just need to keep pushing and it will improve. We just need to keep going with what we're doing, or actually thinking, well, maybe I need to review the diagnosis again and think about revisiting the treatment approach. So I think those are the situations where there's diagnostic uncertainty and the other tools that aren't giving me the answer, that I would move to dual energy.
Yeah, very, very helpful. I really appreciate that deep dive into the story of this manuscript and the background of how you use these tools in practice. I'm going to change direction now and talk to you both a little bit about your careers. And Dansoa, I'm going to ask you first. So you've been in your PhD program, I think at least 2 years, maybe longer now, but you've been
Third year now.
Yeah, so you've been quite prolific in that time. When you reflect on this journey, do you think there were any baseline characteristics from before your PhD that might have predicted your success as a graduate student?
Before my PhD, I found that I'm able to work more efficiently if I have a thorough understanding of what I'm doing and why I'm doing it. And so a big thing I learned during my honors research year was to take time to understand a topic or a task and then ask those with more expertise for help to further my understanding. So making sure I have a good understanding of what I'm doing has been a great predictor of success for me, I would say.
Yeah, and then you obviously have been able to kind of generate a lot of work in that time. Writing manuscripts takes a lot of time, analysis of these big data sets, generating results. How do you get it all done? Are you a person who likes to beaver away late at night, or are you more of an early bird? And when you write, are you writing in complete quiet in the library, on the train, or at your local coffee shop?
Actually talking to Nicola about this the other day. I'm not an early bird. I prefer just to stay up late. But yeah, I do most of my work in our group's office space. So we're on the lower ground floor. So it's very quiet and it's great for my concentration.
Does that mean you're in a basement?
We're just above the basement.
And so obviously mentorship is also very important in the PhD journey. I wondered if you could share a little bit about your mentors, and do you have any tips for people just starting out on how to find a good mentor and how to maintain that mentoring relationship?
I think I've been very, very lucky with supervisors and advisors for my PhD and actually also back during my honors year. I think one of the most important things in finding good mentorship is looking for people or finding people who inspire confidence in you. So after I emailed Nicola about my interest in working on her remission and gout project for my PhD, we had a Zoom call before I actually applied for the course. So for me, it really helped to talk to her about the work that she does and then kind of hearing how I could fit into the project as well. And Nicola and I have weekly meetings. She's a very busy person, but we make it work. And during those meetings, we go over what I've done or what needs to be done and what the end goal is. And I think that consistency has been great and it's definitely kept me on track. And I think having those meetings has actually done a lot to help maintain our healthy mentee relationship during this PhD.
Those are all good tips. And I can imagine anyone who has a Zoom call with Nicola would actually want to start doing research with her because she's got so much energy. So Nicola, from your point of view, because you must have many, many, many people queuing up to be your trainees, how do you identify the candidates that you're going to select and sponsor and mentor? And in your opinion, what are the predictors of success that you look for in your future PhD students?
Yeah, so I think there's a couple of ways that I identify potential PhD students. So one is the pathway that was the way that Dansoa and I met, which was essentially I'd advertised this as a project and Dansoa applied for it through our university student recruitment process. And I think certainly in that situation, I like to have an interview, really sort of have a good look at the CV and just really get a sense of the student, of their goals, of their strengths, of the things that they've, had challenges with, and often actually get a bit of a reference check as well. So, I think you do have to do that kind of due diligence, I guess. And then the other way that I have often found students as well is those who have worked with me in a clinical setting, particularly as clinical fellows, who then decide to become or want to become clinical academics. And I think that's probably an easier route for me because I've worked with those people before, so I have a sense from a different context, the clinical context, actually, how they're going to work within an academic sense as well. So I think that it's really just making sure that you're going to be a good fit. And I think as far as predictors of success, having supervised many, many graduate students now, it is a hard journey. It's not something that is easy. There are often really difficult things that occur along the way. And so I think the person does need to be very organized and actually just be able to keep going even when things don't work well. So there is a degree of you've just got to keep going, even though it's really hard sometimes. And it's important, I think, as a supervisor to be able to put those situations in context and support the student as that occurs. I think there's also some things as a supervisor that I find really help students. So I think it's very important for the project to be manageable, to be done in bite-sized pieces. So if one thing falls over, the whole thesis doesn't fall over. And the other thing I really encourage students to do, and I think Dansoa has done this really well, is to write as you go and to actually achieve those pieces of work as you go, because it makes it so much easier when you come to the end of putting the thesis or the dissertation together to actually have most of it written so that you don't have just a terrible time pulling the whole thing together. And I think that's a really key thing for a successful PhD thesis. And I think the other thing which is really important is students need dedicated time. And so I think the students who have the greatest success are those who actually do have financial support and are in a position to actually have space to be able to focus on the work. And I think we do need to recognize that it's very difficult for a lot of students, and often there's a lot of financial challenges around being a graduate student. And really it's important for students to have the space to be able to do the work, which it can be very challenging from a financial perspective. So Dansoa, I think, has done, she's had a University of Auckland doctoral scholarship, which I think has been really fantastic because actually it has allowed her to have the space to be able to do the work during work time. And really, I think these types of fellowship are incredibly important to support academic development.
Yeah, no, it's incredibly important to hear that and to hear you articulate that so well. So you're also one of the very few female chairs of medicine that we've had on this podcast. So I've got to ask you a little bit about your own career journey. What drew you into academic leadership? And do you have any advice for other people who might want to follow a similar path?
Well, it's such an interesting question. So I've been head of Department of Medicine at the University of Auckland now for about almost 2 years. I've worked in this department for a long time. So I've worked as an academic, professor of medicine. I've been, clinical academic, research active in the field of rheumatology and gout. And, I've had various opportunities over the years to take on leadership roles. And for a long time, I have to say, I didn't make a lot of eye contact. And I tried to and I didn't take those opportunities. And I think that was probably the right thing for me to do at the time. I had a number of opportunities quite early on in my career, and I really felt I needed to embed my academic career, my research work, and also, of course, my clinical practice. And then this opportunity came up about 2 years ago. And I think that I was in a position in my career where actually it was the right time for me to do this. And so I just kind of leapt in. And I have to say, I've really enjoyed it a lot more than I anticipated. And I think it's a really exciting opportunity to be able to support other members of my department who do really amazing work and to lead change as well. And I think having been in this department for many years, I worked in it. I kind of have known the things that work really well and maybe and experience the things that work really well and the things that maybe haven't worked so well. So it's actually a really fantastic opportunity at this stage of my career to take that on. So I guess what I would say is it's not always going to be the right time for people, but actually, if it's the right time, go for it.
That's really great advice. So were there mentors who supported you along your journey?
I think I've been very lucky. I've had a number of mentors through my rheumatology career, through my academic medicine career, and then through my academic leadership career. So I became a rheumatologist because I did a summer studentship as a fourth-year medical student with Professor John Highton, who was a really amazing professor of rheumatology in New Zealand. I worked with Professor Fiona McQueen for many years, who was the first woman rheumatology professor in New Zealand, really amazing academic rheumatologist who did a lot of the pioneering work on MRI and rheumatic disease. And then I also have a very supportive academic leader, Professor Philippa Poole, who who's my boss, who again was very supportive as well. So I think I've had both men and women who have supported me throughout this journey. And I think being able to see another woman in that role where I'm heading has been incredibly important. So I think particularly for Fiona and also for Philippa, that's been very important for me.
And as a lifelong learner, what lessons have you learned along the way? Or better asked, what lessons have you learned that you're willing to share?
Well, I think that academic medicine and all medicine really it's teamwork. And I think I would say, find a team that you work really well with. And I think I've been incredibly lucky in New Zealand there are just amazing rheumatologists here and academic rheumatologists. And I think I was really lucky working in the gout space that we had just a whole group of us who saw the need. There's a huge need around severe gout in New Zealand. So, Lisa Stamp, Tony Merriman, Rebecca Granger, Will Taylor, we've worked together a lot and really worked cohesively as a team in this area. And I think that's made a huge difference. And I think I would also just emphasize, and I'm sure you know this as well, Vicky, that, rheumatology is an amazing career. It's such a great specialty. There are so many opportunities to do different things in rheumatology. It's such a challenging specialty. It's been an amazing career choice, I think.
I completely agree with you. You're never bored in rheumatology. That is sure true. I want to thank you both, Nicola and Dansoa, for sharing your work and your career experiences with us today. I know you got up extra early to record this show, and I really appreciate you sharing your predictions, both on gout and on a life in science.
Thank you.
Thanks.
And a huge thank you today also go to the wonderful patients with gout who participated in this study, which, as Nicola pointed out, was not an easy one to do. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media, email us at podcast@rheumatology.org, and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.